So I'm, as John Moriano, my dear friend, told you, my name is Richard Silver, and I'm up here in New York. The weather is bad here, as it is all over the United States. But it really is a great privilege and pleasure to be here with you this morning. As Ruben said, I've been involved with this conference since 2000, and even the organizing conference, which was in 1999, and with Joyce Niblack. And she was a lovely lady. Her husband was a gracious, delightful host, and we used to spend time after the meeting in the lovely countryside, Scottsdale, with them and go out to dinner and spend take our post-holiday break with them. And this has become really a very unique Congress for patients, and it really is a pleasure and privilege for me to participate with you, with Ruben and John, Angie, David Alexander, and many other folks that we've gotten to know over the years. So my charge was to give an update in managing Polycythemia Vera in 2021. Next slide. My disclosures are, may I have the next slide? Hello? Yeah. I'm involved in many drug company trials, and which I won't bother to tell you about. And my main disclosure, because we're going to be talking about interferon, is Pharmaceuticals, the Speakers Bureau, and I'm a consultant for that pharmaceutical company. Next slide. So PV patients have a shortened survival according to Mayo Clinic data dating back to 2014. And before everybody in the audience who has polycythemia gets upset, I want to make sure you understand that this is an old slide, 7 years ago, 2014, and our results, as you will see, have improved substantially, and as you have heard, we've made great progress in the MPNs. But as it was reported in 2014, compared to expected survival, that of patients with PV is shown in this curve, and the lower left was about a 13-year median survival, and we're going to show you how we've improved that substantially over the years. Next slide. And this is the difference between the expected and the survival of age-corrected patients of the same age without polycythemia vera. Next. Now, what was distressing, according to the investigators in those days, was the fact that no improvement had been made according to their review. And you can see that with regard to the normal survival, expected survival, and in the various time periods, that nothing substantial had improved. And I'm going to share with you today the advances that we have made in the clinic due to the efforts of all of us. Next slide. So we all agree that the initial treatment of PV must be to phlebotomize patients. And you all know, because this is an experienced group, it's because blood is too viscous in the polycythemic patient, and you have a tendency to thrombose. We must or should adjust for the gender difference between men and women, the target hematocrit being 45 for men and 42 for women. And this difference in red cell mass extends to all vertebrates. There is this 10% gender difference, and it should be addressed. And we do that routinely at Weill Cornell. Next. So after the initial phlebotomy treatment, with which we all agree, we must assess the subsequent phlebotomy requirements. And this is not done routinely because there are no records that are really kept well in general, because patients often have phlebotomies at different locations. But at Cornell, we had a research program. Next slide. Next slide. And during the first year of treatment, is my face blocking this screen? I can't tell. Hello?
No, that's good.
Okay, so you can see that for 34 patients, we divided these patients into quartiles, And there was a significant difference between the phlebotomy requirements of patients with PV, and they range from 1 to 25, as you can see in the bottom row. The median was 7 and the median was 8. And the average patient with polycythemia vera requires about 8 phlebotomies during the first year of treatment, the average. But it's not reasonable to compare a patient with a high phlebotomy requirement to that with a low phlebotomy requirement with respect to evaluating medication. And that's obvious because phlebotomy requirements really reflect marrow activity, and that reflects intensity of disease. Next slide. Next slide. Now, I don't want to go into this, but Ruben and John said, they always insist we bring new things to this conference, and this is a drug I want to tell you about just in passing because it's a hepcidin antagonist. It's on the clinical trial in many of our centers, including our own, MD Anderson, of course, with Rubens and Mayo and a lot of places around the country. It's a hepcidin mimetic, and on the left of this rather blurry slide, you see the phlebotomy requirements, and on the right, you see the phlebotomy requirements have been abated by the use of this drug, which affects iron metabolism in patients with PV. It's a drug, it doesn't even have a name. It's called by number PDG13, and it's a drug that may abate the number of phlebotomies that people require and may be useful even during the course of their treatment, because as we all know, getting phlebotomies can be a rather painful and annoying event, and this drug, when administered every 3 weeks, may affect iron metabolism, so it may avoid that. I'm sure you'll be hearing about this drug in the future. Next slide. Next slide. So the treatment options in PV after the initial phlebotomy, where we have the targeted has been reached of 45% in men and 42% in women, are 4. We have phlebotomy to be continued, hydroxyurea, interferon, and then ruxolitinib after hydroxyurea resistance or failure. Next slide. So how do we make our choice? Well, the risk assessment, which many hematologists in the United States and abroad follow. ELN is the European Leukemia Net. It's like the NCCN guidelines in the United States. It's the Guidelines Commission in Europe. For low-risk patients who have been so defined as under age 60, who have had no thrombotic events, those patients have been recommended to continue with phlebotomy and aspirin to avoid thrombosis with the targets that we just mentioned, or they don't correct for gender. And high-risk patients, those more than 60 years of age, with a history of a thrombotic event, and those patients get cytoreduction either with Hydrea, which is most often used in the United States, and aspirin, again with the same target. Our objection over the years to this schema has been the fact that low-risk patients thrombose, and that we're sitting on a powder keg waiting for an event to happen in a low-risk patient, then they become high-risk, and then they become actively treated. And further, since polycythemia is a neoplastic disease, as we now know it, it's best to treat these diseases early rather than late. But let's see what happens with a low-risk patient who is treated with phlebotomy. Next slide. This, again, shows you the national guidelines that I have just mentioned, also paying attention to the fact that we also have to address cardiovascular risk factors. We're appreciative of the fact that patients with diabetes or hypertension or high cholesterol or obesity may add to the risk in both low risk and high risk patients. Next slide. Next slide. So at would you go back, please? Go back. Whereas at Weill Cornell, we believe that all patients, both low risk and high risk, should be treated with interferon. And I am going to show the data today with you, share it with you, why we believe that is so, in contrast to what the guidelines recommend in the United States and abroad. Next slide. So continued phlebotomy does have its costs. Related to anemia, we know that clinically there have been several papers published recently that those individuals have more frequent falls, they have thinking disorders, they have a tendency to become demented, there's a proclivity or a tendency to get demented, there's poor exercise tolerance, there's impaired results after chemotherapy, and there is definite evidence that patients who develop a myocardial infarction get refractory heart disease and heart failure because of the iron deficiency anemia per se. And then in addition to these factors, there are many laboratory abnormalities associated with significant anemia of iron deficiency type affecting mitochondria, chromosomal function, and abnormalities that we won't go into now. But clinically, there are many factors related to the anemia iron deficiency anemia per se. Next slide. So this was appreciated many years ago by a French hematologist, a very famous one named Nagin, who pointed out that, in fact, there's poor clinical tolerance, as I mentioned, and also patients complain about the needle sticks and they run out of veins. There was a notice by the old Polycythemia Vera group that those patients who were treated with phlebotomy-only had a much higher risk of thrombosis and other vascular complications. And there's a risk of early progression of myelofibrosis because, in fact, one is stimulating the bone marrow and all the other factors that lead to an active endothelial bone marrow interaction that causes myelofibrosis. Now, these factors had been overlooked, but only recently have been readdressed. And you'll note that this was published in 1994, nearly 30 years ago. Next slide. So Rubin and his group have also emphasized the fact that MPN patients, including PV patients, are highly symptomatic regardless of subset. And these are the familiar symptoms that patients complain of. I'm sure everyone is aware of these. So that it seemed to us that it was unreasonable to continue phlebotomizing patients, even though these were the official guidelines of two authoritative organizations. And in fact, it was recognized years ago by the Polycythemia Vera study group, which was the first organized group, which the Mayo Clinic also belonged to, and played a great role in its organization and science, that suggested that the bone marrow had to be suppressed. Next slide. Next slide. And that suppression was related to the fact that there was a thrombotic rate even in low-risk patients. This is data provided to me by Dr. Bob Bowie, who hopefully will be speaking soon about ET, in which he pointed out that if there was a general population risk factor of 0.6, and those who had diabetes or hypertension or atherosclerosis or obesity, it was increased by a third to say 0.9% patients per year. Even low-risk patients, so-called low-risk patients, had roughly three times the risk of having a thrombotic event as the general population with risk factors, as shown in the second line. And if you were a high-risk patient, you almost quadrupled that risk, as you can see with a figure of 3.14. And there was a significant number of patients who had low-risk PV that nevertheless were at risk for having a thrombotic event. So these seem to us to be inconsistent with just leaving them alone and phlebotomizing patients as a treatment modality. And again, as I said, history repeats itself. This was known years ago by the Polycythemia Vera study group. Next slide. And they used hydroxyurea because it wasn't as leukomogenic as other drugs. And you can see with hydrea plus phlebotomy that the number of events were cut in third compared to the phlebotomy-only group, wherein there was 38.1% of events compared to 13.7% of events over a 7-year period in patients who were treated with phlebotomy only. So why this has persisted is very difficult for us to understand. Next slide, as a recommendation. Now, hydrea is a good marrow suppressant. However, it does have side effects that cause these vicious skin ulcers. There is unquestioned increased incidence of squamous cell cancers by 5 years, particularly in fair-haired individuals. And there is in our opinion, after patients are treated for 10 to 15 years, an increased incidence of acute leukemia. That has never been shown in an unequivocal clinical trial, but it's been our observation. And for these reasons, we don't like this as a primary modality. Next slide. Now, one of the approved treatments, as everyone knows, is ruxolitinib for hydrea resistant or toxic, or patients who are resistant or toxic to hydroxyurea. In the left-hand bar, you can see that the combined endpoint of the RUX study was reduction in spleen volume by 30%, 35%, and hematocrit control. And that occurred in only 20% of patients, only 20% of patients. So it's really not a terribly effective drug if you look at the numbers. Only 30 of those patients who had a 35% reduction in spleen size, and we don't know what the significance of that is, that only occurred in about 38 to 40% of patients, and the combined endpoint was 60%. But these patients in the standard therapy group were patients who are already on or receiving hydroxyurea as well, in about 75% of patients in this group. And moreover, the phlebotomy requirements that we used were very, very low. In other words, they were those patients were receiving only 1 to 3 phlebotomies per year. So this drug was tested in a group that had already been proved to be resistant or intolerant to hydrea, and they satisfied the phlebotomy requirement in a low-risk phlebotomy group. That is to say, only those who receive 1 to 3 phlebotomies per year. Next slide. Next slide. Now, what is not well known is that interferon is very effective in treating patients who have had a large spleen after hydrea failure or de novo. And here you can see that 90% of patients with initial splenomegaly showed more than a 50% reduction in spleen size, whether or not they received private hydroxyurea. We knew that as far back as 2006. Unfortunately, this was a single phase 2 study and was not a randomized trial, and of course did not achieve the recognition factor that randomized trials do, but nevertheless, the data is unequivocal. Next slide. And here you can see the visual impact of a year of interferon therapy in a patient who had had massive splenomegaly in a year after as a single agent. Next slide. So what are the specific activities of interferon alpha that are of interest in PV? Well, this is a biologically significant drug in comparison to hydrea or any other alkylating agent like chlorambucil or even radioactive mimetic drugs such as P32. It suppresses megakaryocytes. It affects PDGF, which is platelet-derived growth factor, which is involved in the fibrosis of the bone marrow. It affects early red cells. It affects the vascular endothelium, and vascular endothelium contains JAK-positive cells, and that maybe play a role in spike vein thrombosis. It's involved in JAK-STAT signaling, and you already heard that from the beautiful lecture on the biology of the disease. And Ann Mullally in Boston has shown that interferon will exhaust PV stem cells and therefore may really basically affect the biology of the disease in that fashion, and is very safe to use in pregnancy in pregnant PV patients, and it's not leukemogenic. Next slide. So in recent years, since there have been so many phase 2 studies, and everybody wants a phase 3 studies. I've summarized the issue of whether or not interferon prolongs survival of PV patients, because a few of us in the United States and many more in Europe, Dr. Kalajian and Hasselbach and Gislinger and others believe that it does, that interferon is a unique drug prolonging survival of PV patients that will significantly change the curve of that which I showed you initially from the Mayo Clinic in 2014. So they've been, we can consider these as large studies, randomized controlled trials, or long follow-up, as you see in the red on the headers on top. There have been 4 recent randomized trials. I'm not going to go into them in detail. They have been randomized and controlled, but their follow-up is only about 5 years to 10 years, 1 to 3 years, with some as patients being followed as long as 5, but really not a huge long-term follow-up. The most important one, I think, is the low PV study coming out of Europe. Dr. Bobby Bowie may talk about that later on, in which patients who are low risk are randomized between phlebotomy and interferon, and the interferon group has been much more efficacious in the low risk group, as we have been saying from our phase 2 data. And we've been saying that for about 30 years since we introduced the drug in the treatment of PV. But at Cornell, we used a sophisticated data collection technique, which we don't have the time to go into, analyzing our 470 patients in our computer bank. This was not a randomized control study, but the advantage was that we had follow-up of patients treated as long as 45 years with a median duration of at least 10 years. And all these patients were treated after a diagnosis had been made using appropriate WHO criteria or radioisotope diagnostic criteria, bone marrow criteria, etc., so that we were dealing with a very homogeneous population. And in fact, 70% of the patients have been treated by only 4 senior hematologists. Next slide. So the first, before we go into that, we do want to mention the ROPEG study, which is a European study with Dr. Gislinger and Dr. Kalajian are the senior authors. They have compared hydroxyurea to interferon. On the left, you'll see that interferon was initially more successful with interferon in causing clinical remission. But after the first year, there has been a persistent superiority of interferon over the years, and at 5 and 6 years, the superiority of interferon over hydroxyurea has persisted. And in the right-hand box, you'll see that the molecular response has been reflected very similarly, that initially there is a higher response rate with hydroxyurea, not very impressive, but as time goes by, the interferon, the curve, the higher curve, shows a much better response compared to interferon. So in a comparative randomized trial, phase 3 trial, the golden sepulcher of clinical trials in a randomized trial, rofuron is better than hydroxyurea at about 5 years. So next slide.
Hey, Dick,
yes.
Can you hear me? You're doing well. Thank God everything's working for most of us. This is your 3-minute warning if you want to.
Okay, so the combined analysis of the hematocrit without phlebotomy and molecular response that I mentioned is from Dr. Bob Bowie. This is, again, preliminary data at the end of 1 year. And in red, you can see the superiority of interferon compared to phlebotomy only in the low-risk patients, therefore suggesting that even in low-risk PV, that interferon is a superior drug to phlebotomy, which is how patients are being managed now. Next slide. So how about our data from the 470 patients followed for as long as 45 years with a median of about 30? You can see here that the median myelofibrosis-free survival is superior by far in interferon-treated patients, with 84% of the patients in the low-risk group, in low-risk PV, compared to 65 and 55 in hydrea and phlebotomy only. So this would suggest initially that in this retrospective review that interferon treated in low-risk patients does prevent the subsequent development of fibrosis in patients as they evolve in their disease. Next. And the interferon is a disease-modifying agent. On the left, you see pre-treatment hypercellularity, post-treatment normal, and in the lower box, you can see a reduction in fibrosis on the left from a grade score of 2 to 3 to 1 to 0 on the right. And this has been confirmed by the folks at MD Anderson. You can see that in the right diagram in Dr. Serge, his group, showing again that the bone marrow improvement is cumulative over time with the use of interferon. Next slide. And by statistical mechanisms and techniques, which we won't go into now, there's a 9% myelofibrosis risk reduction per year of interferon treatment. So that means the earlier you start, the better it is for preventing myelofibrosis. Well, how about overall survival? Next. So overall survival in high-risk patients, as you can see, the median survival is way out beyond 20 to 24 years. We haven't even reached it with patients on interferon. 66% of our patients have lived 20 years or more, 40% with hydrea, and only 14% of the phlebotomy-only group. So you can see how we have improved our survival time over the last decade, and particularly the use with interferon. Next slide. Next, and using the same calculations, the longer the time on interferon, the reduced mortality, and that comes out to about 6% per year on interferon. Next slide. So what are the limitations? We always have to mention that. We're very concerned with patients who have developed any type of autoimmune disease or neurological symptoms. The issue of depression and interferon always comes up. However, working with our psychiatrists, we've had many patients who have had mild depression and been treated with psychiatric assistance without any difficulty. It's of interest that in our 470 patient group that the discontinuation rate in our hands has only been 13% for interferon and 16% for hydroxyurea. But if you look in the literature, it's about 20 to 25%, or give or take, depending upon the enthusiasm of the physician and how long the patient really wants to hang in there. The usual limitations are dose-dependent, as listed above, and they don't indicate the use of interferon. They're usually mild and can be handled easily with analgesics, as many as you know. Next. I got to get some time off for saying next, John. So in our opinion, in conclusion, interferon should be considered for both low-risk and high-risk patients, as you can see here. The NCCN guidelines and ELN guidelines, we believe, should be changed. And it should be noted that Dr. Barboui is chairing a committee of the European Leukemia Net looking into this as we speak. And we believe that even in high-risk patients, as so-called high-risk patients, interferon has been unequivocally shown is to be better than hydroxyurea. Next slide. So I think we've made a lot of progress. You've heard Ruben and John say that. If you want to know who that figure is, this was a shot I took of John Camoriano climbing this big rock. If you got real close to him, you'll notice it would be him. And we're almost to the top of the PV rock, conquering this disease. Next slide. And sometime in 20 whatever, we hope we will conquer this illness and plant the PV flag, just like the Mars flag has been planted by the space folks at NASA. And we think that will be an equivalent accomplishment as far as we're concerned. Thank you very much for allowing me to share my